Greetings, everybody. It's my greatest honor to present the IOA Golden Jubilee Oration 2019 at IOCON, Kolkata. I would be discussing diagnosis and management of osteoarticular tuberculosis, a drastic change in mindset needed. It is not enough to just diagnose tuberculosis. I represent my students and fellows, Department of Orthopedics. At the outset, I sincerely thank my patients, my family, my departed family, my teachers, my friends, guides, and philosophers. The think tank and energy source of Hinduja Hospital, Dr. Vikas Agashe, microbiologist, TB masters, and infectious disease specialist at Hinduja Hospital. My supports from orthopedics, some more friends and supports from orthopedics. I also thank the pioneers who have helped thousands of orthopedic surgeons and in turn millions of osteoarticular tuberculosis patients, Professor Tully, Professor Anil Jain, and Professor Rajshekharan, and many others like them. And last but not the least, the pillars, my nursing home, Hinduja Hospital and staff, and most important, Bombay Orthopedic Society. At the outset, friends, please excuse me if my opinions are diagonally opposite to those of TB experts present here or elsewhere. I take you back more than 60 years. Dr. B. Mukhopadhyay, Professor Dr. B. Mukhopadhyay, gave Hunterian lecture to Royal College of Surgeons, England in 1955. And the title was Role of Excisional Surgery in Treatment of Bone and Joint Tuberculosis. He concluded his lecture by saying, the struggle against tuberculosis disease has been hard, long and costly, but today we appear to be on threshold of success. Friends, 60 years ago, he said we are on threshold of success. But there's a big but. A lot can and did happen in 6 decades, and that was HIV epidemic, which changed the entire face of tuberculosis world over. And today, there are papers from India challenging or asking whether India is ready for the challenge of drug-resistant tuberculosis. And the conclusion is regretfully no. And therefore, I say a drastic change in mindset is needed. It is not enough or adequate only to diagnose osteoarticular tuberculosis. I start with a case. A 10-year-old girl who had presented to us just last year. She had a large ankle swelling, she had fever, weight loss, and MRI also was highly suggestive of an infective lesion. So it just perfectly fitted into clinical radiological diagnosis of tuberculosis of the ankle. Should we start ATT? Majority of orthopedic surgeons would say yes, this is a classic case of tuberculosis of ankle. Some would say, I want a tissue diagnosis, I want histopathology. So this is her histopathology consistent with tuberculosis osteomyelitis. Should we start ATT now? Some more, or rather a very few would say culture is the gold standard. This is our culture, Mycobacterium tuberculosis, complex isolated. So this is a gold standard for diagnosing osteoarticular tuberculosis. Now at least can we start ATT? Friends, as per our protocol, we asked for a drug sensitivity test and were in for a very rude shock, and she was resistant to 10 anti-TB drugs. She was sensitive only to clofazimine, linezolid and PAS. Friends, a 10-year-old girl resistant to 10 ATT drugs. Was she immunocompromised? No. Had she taken ATT in past? Never. So, in short, she had primary resistance, or she was primarily resistant to these 10 anti-TB drugs. So, how do we treat her? There are hardly any options available. Dr. Zari Rudwadia started her on delaminide, a drug from Otsuka Pharma, Japan. You will not believe the monthly cost of treatment is 1,50,000. This is her after 14 months. She has made an excellent recovery. But how many of our patients can really afford this? So, what changes I am suggesting? I am suggesting that we should do TB culture, drug sensitivity in all cases, in addition to, of course, clinico-radiological diagnosis or impression, as I would say, histopathology and gene expert. So what is the current mindset? Current mindset is clinico-radiological diagnosis is acceptable in the disease endemic region. Is there an evidence for this? Yes, a recent evidence. ISO 2019, evaluation of healed status in tuberculosis of spine by MRI, tomography and contrast imaging. I am just copy pasting from this article. These cases were diagnosed clinico-radiologically and by MRI and or histopathology or fine needle aspiration cytology or bacteriology or molecular tests. But as many as 28 out of 37 were diagnosed by clinico imaging studies, including MRI findings. So majority were diagnosed on clinico-radiological grounds. Another current mindset is culture yield in osteoarticular tuberculosis is poor. This is the evidence. 2016 paper, 6 out of 120 patients only had positive culture. Or another paper in 2017 by Prasad et al. Both are excellent papers and the culture yield is 10 out of 51. So the culture yield is generally poor. Why am I suggesting culture and sensitivity in every case? If the culture is going to be negative, is there anyone in India or has there been studies in India where good culture yield has been possible? Yes, I am saying this on not on the basis of this 1 in million case, but on the basis of 2 projects done for Bombay Orthopedic Society from 2004 onwards. It started off in 2003 during my post-operative round. I had just operated on a patient for ankle synovectomy, and as soon as I met the patient next day, he said, "Sir, I hope you have sent my sample for TB culture." So I said, "No, I've gone one step beyond. I've used the latest technology. We have done frozen section and confirm your tuberculosis there and then. And the culture is almost always negative." He very politely said, "Sir, I beg your pardon, but you should have sent my TB culture." I was honestly surprised by this discussion, and I wanted to find out what is the current status in Mumbai. So I did a pilot study amongst BOS members, and 60 surgeons replied. I had asked them about culture studies, method of sample collection, and their perception about tuberculosis. Majority said this is a futile exercise, waste of money. About 10% were doing it occasionally. There were only 2 who were doing it on a regular basis. Responding to my query about method of collection and containers, majority were using sterile soft stick or FNAC. However, everybody mentioned that last few years, some patients don't do well. Now that set the ball rolling. I wanted to find out why some patients don't do well. So next week I met our microbiologist, Dr. Camila Rodriguez, and she said, possibly you are dealing with resistant cases, but you will never know unless you unmask it. By that, Remember, this is a positive bacterial disease, and unless you improve your culture yield, you will not be able to unmask the problem. And she said that improving culture yield would mean an appropriate sample, appropriate containers, early transport, and appropriate technology. By appropriate sample, just avoid the swap stick and FNAC. Take deep sample, adequate sample, collect granulation tissue as well as pus without any additive in a sterile leak-proof container, and then we would do various tests. We will do the conventional LJ as well as the new, which was recently introduced then in 2003, MGIT or Mycobacterium Growth Indicator Tube, which is a liquid medium, is an automatic medium. The tubercle bacilli grow in just 2 to 3 weeks as opposed to 6 to 8 weeks that are required for LJ, and it detects MTB complex with which produce almost a similar clinical disease. I again discussed this with Dr. V.R. Doshi, and he said that yes, you must do a study, but don't restrict yourself to only Hinduja hospital patients. There should be no bias. Try and do this study over entire Mumbai. The study should involve clinico-radiological, histopathology studies as well as culture and drug sensitivity tests. And Hinduja Research Society sanctioned a handsome grant of almost 7 lakhs for this project 16 years ago. I proposed this in annual general body meeting of Bombay Orthopedic Society, and the project started in 2004. So friends, this is a story how we at Bombay Orthopedic Society changed uncultured Mumbai to partially cultured Mumbai. So the first project was started in 2004 with inclusion criteria for of suspected cases of osteoarticular tuberculosis and patients already on anti-tuberculous drugs but not responding. And they had to be willing to undergo biopsy and sharing clinico-radiological details. Our first step was to inform and involve BOS members. We would go to various meetings of BOS. My fellows used to distribute pamphlets and containers, stressing on the minds of BOS members how sample has to be collected and the inclusion and exclusion criteria for these patients. We also told them that they can send the patients or they can send a sample with clinico-radiological details to Hinduja Hospital, where all the tests would be done free, including image-guided biopsies. And we decided on sample collection guidelines for image-guided biopsy, instructed or informed the radiologist not to use an FNAC but a wide bore needle or a gun. Arthroscopist, we told them to collect sample before putting in diluent, and during surgery also we told surgeons that they themselves have to collect the samples, use multiple leak proof containers, and pus as well as granulation tissue has to be collected. And we performed gram stain, Zn stain, aerobic, anaerobic cultures, histopathology as well as TB cultures by these two methods. We had decided not to assume any patient as only osteoarticular tuberculosis. So over a period of 28 months, 36 surgeons contributed to clinical details as well as samples of 93 patients all across Mumbai. And we were surprised to find 13% of them did not have tuberculosis, and the commonest was pyogenic infection. And as many as 58% cases, the MGIT was positive, and 42% of the cases, LJ was positive. So the culture positivity was significant even in this heterogeneous sample. 15 patients were resistant to at least one anti-tuberculosis drug. 10 patients were multi-drug resistant. 2 were extremely or extensively drug resistant. The resistance pattern varied significantly. Youngest patient was 18 months old, but what was shocking was 40% of patients were under 10 years of age. And none of them, not a single patient, was immunocompromised. There were 3 patients who had never received anti-tuberculosis drugs, or in short, they had primary resistance. Like this young boy, just 18 months old, was resistant to INH, rifampicin, or in short, he was MDR. There were 12 patients who were already on anti-tuberculosis drugs. So possibly they had an acquired resistance, or maybe they had missed primary resistance. Like this patient who was operated several times, several samples were collected, but only histopathology was done. And during the project, we picked up that she was resistant to INH, rifampicin, and ethambutol. So in short, if we had started or modified treatment based only on clinical suspicion and imaging, almost one-third patients would have had poor result. 12 cases of non-TB as well as 15 cases of resistance. Another very shocking finding was pediatric population was developing primary resistance, a fact that was stressed by chest physicians as well, and this was a matter of great concern. Question is, why was pediatric population developing resistance in Mumbai? The answer lies in this hallmark paper. The paper is titled as HIV and Tuberculosis, Partners in Crime, published by Dr. Maniyar and his colleagues in Indian Journal of Dermatology and Venereology in 2006. They assessed more than 8,000 patients over 6 years, and incidence of TB in those patients was close to 94%. Of the culture positive patients, 42% were resistant to anti-TB drugs. So all these patients behaved like epicenters of resistant TB, infecting children, and patients who had good immunity or children who had good immunity developed primary complex with resistant bacilli. Not so fortunate patients and patients who had poor immunity developed a full-blown disease with resistant bacilli. We published this as Osteoarticular Tuberculosis Diagnostic Solutions in a Disease Endemic Region in 2009 in Journal of Infection in Developing Countries. Once we realized that the culture yield can be good, Bombay Orthopedic Society and Hinduja Hospital initiated another project in 2010. Bombay Orthopedic Society gave a grant of 12 lakhs, and a senior orthopedic surgeon friend of mine also contributed handsomely, and he donated 1 lakh. We wanted to find out why some patients don't respond to anti-TB drugs. So in short, we selected clinically refractory cases, and we decided to include cases from 3 months onwards as against the general guidelines of 5 months. So in short, the inclusion criteria where all this is a common knowledge: persistent pain, persistent swelling, development of new lesion, so on and so forth. So our first hypothesis was the commonest cause of poor response is resistance, which is varied and therefore needs targeted treatment and not empirical stepping up of anti-TB drugs. I'll illustrate this with a case. In 2012, we had a young boy who presented with discharging sinus and ankylosed left elbow, and he had this discharging sinus for off and on for several years. You will not believe that at presentation, he was on anti-TB drugs continuously for 16 months and intermittently for 9 years. I'm just tracing the history. 1996, he was diagnosed as tuberculosis of the elbow based on histopathology. Anti-TB drugs were started. Year down the line, he had D1-2 destruction. He was again operated and anti-TB drugs continued for another 1.5 years. 1998, the elbow lesion recurred. He was explored and arthrolyzed. Anti-TB drugs were continued. Over a period of next many years, he was operated several times, as you can see here. 2007, he had multiple sequestra. Again, debridement was done. Histopathology proved tuberculosis. His culture was negative, and he was empirically put on all these drugs, primary as well as second line drugs. So he was included, when he was included in the project in 2012, you can see he had a significant destruction of humors. We explored, debribed him, and the culture was resistant to INH, rifampicin, pyrazinamide, ethambutol, and streptomycin. These were the susceptible drugs, and then he was treated appropriately with second line drugs. So in short, for the first time in 16 years, and after several surgical procedures, his TB culture was done and was positive. Therefore, antibiotic study could be done. And in short, we went beyond simply diagnosing tuberculosis through Bombay Orthopedic Society project, and we could give targeted therapy for anti-TB drugs. This is him after a year, and 2019 there was no osseous lesion and no recurrence. However, just a few days ago, he developed a small soft tissue lesion, and which turned out to be resistant TB. Just showing that this is a very, very slippery disease. Second hypothesis is not all have resistance. There could be other causes for poor response, like a sequester. This middle-aged person presented with persistent discharging sinus for 5 months. The culture initially was pan-sensitive mycobacterium tuberculosis. And you can see there's a small sequestrum in the head of first metatarsus. So moment we excise the sequestrum, the sinus healed and he settled very, very well. Third hypothesis, not all non-respondents have tuberculosis. This middle-aged person was on anti-TB drugs for 6 months based on an MRI report of early infective process at D11-12. She had significant pain in that region and therefore she was included in the project. We studied this case in detail. We realized that she was operated for CA breast 3 years ago. So we suspected that she had metastasis. We repeated the MRI, which then reported as highly suggestive of metastatic lesion. We did a CT guided biopsy, which unfortunately confirmed metastasis from CA breast. Another illustrative case, a young boy had persistent pain in dorsal region. He was on anti-TB drugs for 11 months with a MRI report of posterior element Cox. Question is, do we step up anti-TB drugs? Again, we evaluated the case very well, examined him in detail, reviewed the investigations, and we suspected a non-tuberculous pathology. So we asked for a CT scan, and which revealed osteoma. Radiofrequency ablation relieved him of his pain completely. So in short, we had as many as 16 patients in this group of 89 patients who did not have tuberculosis, and there were varied, many different lesions in this group. As many as 16 out of 89 patients were suffering from non-tuberculous etiology, varied diagnosis from non-tuberculous mycobacteria, fungal infection, metastasis from breast carcinoma, so on and so forth. And most of these patients were diagnosed as tuberculosis based on the MRI report by imaging consultants. Actually, radiologists need to be sensitized about Professor Anil Jain's work about diagnostic features of TB spine on MRI, which is acknowledged world over. Unfortunately, today, every signal abnormality is often reported as possibility of COX. MRI reports are considered as gospel truth and anti-TB drugs are started. This has caused major issues. Our fourth hypothesis was, instead of cutoff of 5 months for considering somebody as non-respondent, we felt 3 months cutoff is needed. We need to pick up resistance early, especially if the diagnosis is clinical radiological. And we were really happy that we kept 3 months as cutoff and not 5 months. We would not have included these 22 patients. 9 of them were resistant. And you can see the resistance pattern, which was really quite troublesome. And we were happy that we picked them up early and started appropriate treatment. So, to summarize, this is the baseline data of non-respondents. We had 89 patients with a mean age of around 25. 37 out of 89 were multifocal. There was a family history of tuberculosis in 29 patients. What is important was 72 out of these 89 patients were being treated with anti-TB drugs without tissue diagnosis. And of the 17 where anti-TB drugs were started after tissue diagnosis, drug sensitivity was done only in 8 patients. So in short, of the 89 patients enrolled, 5 were not subjected to biopsy, 3 were lost for follow-up, and in 2, the diagnosis was revised based on the imaging reports, 1 stress fracture and 1 seronegative arthropathy. 13 were totally non-representative samples. Out of 71 samples, out of 79 patients, 36 patients, histopathology as well as culture were positive. Of these, 33 were resistant to at least 1 anti-TB drugs. 24 were multi-drug resistant and 3 were extensively drug resistant. 21 out of these 89 had histopathology positive but culture was negative. So they were considered as probable TB. So to elaborate on drug resistant, 36 patients were culture and histopathology positive and 33 of them were resistant to at least 1 drug. Does it mean that clinico-radiological diagnosis has no relevance today? On the other hand, clinico-radiological impression is extremely important. All I am trying to say is don't consider it as diagnosis. So that clinico-radiological diagnosis term should be changed to clinico-radiological impression. Because finally there would be some patients where all tests would be negative. And this clinico-radiological impression will go a long way in suggesting whether we repeat the biopsy or do open surgery or finally do empirical treatment. There's some very scary data that has come out of our study of these 2 projects. We had really never expected this. First, 9 patients had primary resistance to second-line drug. For example, this 17-year-old boy who had who had pulmonary tuberculosis 2 years ago, he was treated with primary anti-TB drugs. 8 months after that, he developed lesions and I'll just go back. This case, yes. This 17-year-old patient who had tuberculosis of foot and tibia. 2 years ago, he was treated for pulmonary tuberculosis with primary ATT. He was comfortable for some time. and then developed lesions in tibia and foot. He was again started on primary ATT, and 8 months down the line, he presented to us because he was not settling. Both these lesions were not settling. He had very poor response to ATT, and he turned out to be resistant to these 11 drugs. So he had never taken streptomycin, kanamycin, ethionamide, oflox, moxiflox, amikacin, capreomycin. Still he was resistant to them. So obviously he had primary resistance to these drugs. We modified anti-TB drugs. We arranged private donors through BOS, and this is him 1 year after stopping ATT, absolutely comfortable and ever grateful to Bombay Orthopedic Society. The second scary truth was when we compared findings of our two projects, the resistance pattern had worsened significantly since the previous study, and just in a matter of 4 to 5 years. So this is comparison of drug resistance between our two projects, first between 2004 and 7 and second 2010 onwards. Here you can see in the first project, pyrazinamide, no patient was resistant to pyrazinamide. While here, 4 out of 5 or 80% were resistant to pyrazinamide. Again, ethambutol resistance has doubled. Streptomycin resistance had increased. Ethionamide again resistance has doubled. Oflox resistance has doubled. Moxiflox, there was not a single patient resistant to Moxiflox, as many as 50% were resistant to Moxiflox. And amikacin, clofazimine, capreomycin, not a single patient was resistant to that. All that resistance has started now. So this is a very scary situation at this point of time. Similar culture pattern was noticed in publication by Dr. Kapil Mohan and Nemi in spine patients at Hinduja Hospital, a tertiary referral center. So finally, friends, are we returning to pre-antibiotic era? This slide keeps on appearing time and again on the net. Initially, most of the patients had drug susceptible TB. Then MDR appeared in 1990. XDR appeared in 2006. And now people are wondering whether we are entering the era of total drug resistance. Mind you, friends, such grave situation in pulmonary tuberculosis has long been announced to the world by my friend and colleague, Dr. Zarir Udwaria. 2012, he published a paper called Totally Drug-Resistant Tuberculosis in India. He published another paper in 2016, Totally Drug-Resistant Tuberculosis in India. The bad just got worse. This did cause a political storm. Maybe the title could have been different. Maybe resistant to 12 drugs does not mean total, but still, this represents an exceedingly dangerous situation and needs tremendous political will to tackle this situation, which unfortunately, I want to cut that.
Yes.
Let's not become political. I am sure I'll be geared after this oration. People will say this is because your Mumbai is dirty. Mind you, friends, I'm still requesting you that we should change. Because Mumbai is a leader, India follows Mumbai. And beware, the problem has already started. The very first assessment or survey for drug resistance in India was conducted by Ministry of Health and WHO from 2014 to 2018. And of the new cases, there were 23% cases who were resistant to at least one drug. That means 1 out of 4 patients was resistant to at least one drug and will not have an appropriate response if you start empirical treatment. And as many as 3% patients were MDR in new cases. And that's a very scary situation. Another paper from a hospital in Chhattisgarh, rural center area. You would never think that in villages there would be resistance. The study period is from 2015 to 17. Of the 417 samples which were assessed by LJ medium, again, patients who were not on treatment, 8% had INH monoresistance and 3.5% had MDR. So this in even rural area, not in Mumbai. Now, our national strategic planning which published their vision in 2017, felt that by 2025 we should be able to eliminate TB. And that's a really ambitious plan. There's another paper in Lancet which actually refutes it. They say that from 2016, if there is no change in tuberculosis management practices in India, in just 16 years, there will be almost 300% increase in MDR infection, and 85% of them will be primarily resistant. So that means without doing culture sensitivity, you will not and you should not treat any patient with suspected tuberculosis. To summarize, good culture yield is possible by appropriate sample, appropriate containers, and appropriate tests. Once upon a time, friends, TB bacilli were obedient and empirical ATT worked. Today they defy us. Our anti-TB medicines will be governed by them. Friends, we have just taken a peep at a demo. Drug resistance is real and worsening. Children are getting infected with resistant TB drugs, or they have primary resistance. We can't afford to ostrich policy now. It's time we accept that this is a big problem. Someone has to unmask this drug-resistant osteoarticular tuberculosis. And that someone is you, me, and IOA. We must think global. Remember, mankind may be wiped out because of tuberculosis and other infections, but we must act local. We must unmask the drug-resistant osteoarticular tuberculosis. We must sensitize physicians and health authorities to stimulate them to unmask drug-resistant pulmonary tuberculosis. Because finally it is the pulmonary tuberculosis which infects and patients and they suffer from osteoarticular tuberculosis. The a question which is most commonly asked is, do we have facilities pan-India? Yes, friends, we have facilities now. Almost each and every district has gene expert now. There are as many as 750 midget machines in this country. When we started the project in 2004, there were 4 or 5 machines in the country. Today there are 750. And there are many more laboratories with LZ facilities. So we do have adequate facilities pan-India. It is just a question of changing the mindset. Friends, we are in the land of Netaji Subhash Chandra Bose. He said, give me blood, I will give you freedom. I am saying, give me appropriate sample, I will give you freedom from osteoarticular tuberculosis. Thank you, friends.